handle about 10 to 15 cases of complex coronary lesions, which also includes bifurcation lesions. And it also includes challenging anatomy, including the left main bifurcation, LAD diagonal, and LCXOM bifurcation lesions. So around 25 to 30% of bifurcation lesions, we have a challenge in accessing the side branch, especially when the side branches are more angulated and if they are more calcified, and it becomes challenging. So I usually use a provisional stent strategy. So in some cases, usually I use the jailed wire or a jailed balloon technique. And for complex anatomy and depending on case, I use a kissing balloon inflation at the last. So during the side branch expansion, the challenges are maintaining the wire access through the procedure in side branches, complete ostial expansion of the side branches. Then sometimes we encounter a lot of fibrotic or heavily calcified lesions at the side branch ostium or at the bifurcation. These are very challenging. So around 10 to 15% of patients we encounter this, especially in patients who have a tortuous side branches and heavily calcified side branch ostium we experience. Yeah, it is very important, and it saves a lot of time, the fluoro time, the radiation exposure, the amount of contrast use. So especially in complex tortuous anatomy, the trackability is good. We are very happy, and it is very, very important. Especially the open cell design or the hybrid design, we find it very useful for side branch access. It is easy to access the side branch without deforming the proximal part of the stent. Yeah, I've tried a few. The side branch access was pretty easier, and we were able to cross the side branch after stenting the main vessel very easily. It is evolving in the right direction, but my experience is very limited. So I usually measure the success of the procedure by the percentage of stenosis, like complete revascularization and no residual stenosis, good TIMI3 flow in both the main and side branch vessels, and no dissection. All these determine the restenosis rates. They definitely do income. So in my experience, like many patients, we have done just POBA to the side branch and we have come out. So in these patients, the angina persists in spite of revascularizing and good expansion of the main vessel. The side branch stenosis, if not adequately treated, that will lead to persistent angina. And many patients where we went ahead and did complex bifurcation stenting took a long time, and we ensured that there was no residual stenosis at both side branch and the main vessel. The outcomes were good and the restenosis rates were less, and even the angina was also very less in these type of patients. Yeah, definitely. If the stents upcoming are more friendly for side branch access, and if the deliverability is good, and there are good expansion of the stents, we'll be definitely keen in using those stents for bifurcation lesions. Randomized control data, especially across the globe and specific to our subcontinent Indian population, if available, I'll be more keen on using it. I'll also like to have the experience from the peer group, especially the senior people who are doing a lot of bifurcation lesions. If they have a good hands-on experience, I'll be more keen on using it.